Hello to everyone. I am Jessica Goldstein, Education Program Coordinator for ASRM. Welcome to this webinar on preparing for laboratory inspection. Please join me in welcoming my colleagues, Kelly Jefferson and Sarah Ramaya, and today's moderator, Dr. Amy Sparks. Dr. Sparks is the ART Laboratory Director at the University of Iowa. He has served on the Registry Committee and is currently the SART past president. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine and the Society for Assisted Reproductive Technology as an educational resource and service to its members and other reproductive professionals. While this webinar reflects the views of the panelists, it's not intended to be the only approved standard of practice or to dictate the exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn the presentation over to Dr. Sparks to introduce today's speakers.
Thank you, Jessica. It's my pleasure to introduce our speakers today. Dr. Benke, Erica Benke, is the Director of Assisted Reproductive Technology Labs at the Institute for Reproductive Health. She'll be representing the College of American Pathologists today. She earned her Master's of Science and PhD degrees at the University of Minnesota in Reproductive Physiology, following a Bachelor of Science degree in Animal Husbandry from Michigan State University. She is board certified as a high complexity clinical laboratory director by the American Board of Bioanalysts. She served as a lab inspector since 1994, and in 1999, she bravely took on the duty serving as commissioner of the Reproductive Laboratory Accreditation Program for CAP. She's also a member of the CAP Reproductive Medicine Resource Committee. Vicki Livingston will be representing the Joint Commission today. She surveys the standards in the Comprehensive Accreditation Manual for Pathology and Clinical Laboratory Services. Prior to joining the Joint Commission, she served as the Director of Quality and Risk Management for Cannon Memorial Hospitals in Pickens, South Carolina, Quality Reviewer and Medical Technologist at Greenville Hospital Systems, and Laboratory Director at Brandon Hospital in Florida. She received her education and training in medical technology at Upstate Medical Center in Syracuse. She is licensed in the state of Florida as a supervisor of medical technology in the specialties of chemistry, hematology, immunohematology, immunology, microbiology, and molecular biology. She is also certified nationally by the American Society for Clinical Pathologists. With that, I welcome both Dr. Benke and Ms. Livingston. Thank you so much for joining us. Turn this over to Dr. Benke.
I really appreciate being given the opportunity to speak to folks about the accreditation program that we have at the College of American Pathology. It was developed back in 1994 with the cooperation between ASRM and the college in order to try and set standards that will help people run the best lab that they possibly can. The College of American Pathologists, we all call CAP. And the CAP really is involved in trying to champion laboratory excellence. We are a peer-based organization for inspections. That means that when your laboratory is inspected, you're going to have someone that directs the same or similar type of laboratory that you are running. And it may also be accompanied by a second inspector that comes from a more general background lab, and also specialty inspectors that have other assets. If your laboratory happens to have chemistry, you may have a chemistry inspector with it. But all in all, we are following customized checklists that are only set for your laboratory. If you do not do certain parts, those questions will not be on your checklist. The checklists are reviewed every year by the Reproductive Medicine Committee, and we update them as best we can to remain current with situations and current with practices. CAP offers a lot of educational resources to help people get ready for laboratory inspections or even in the throes of an inspection. They have a number of webinars throughout the year. There are some podcasts. We have online training for our inspectors, and we also have items that may be sent out by a broad-based email to update developments that have happened. So CAP is always in the background waiting to help you do your very best. We support continuous improvement, and we really want to see people over time maintain their compliance. We have many labs that go back to the early 90s for the reproductive labs. We've got some labs that are just joining now. So from start to finish, we want to make sure that you're doing your very best. I have absolutely nothing to disclose. We have to go beyond just compliance. We don't want to just meet standards. We want to go beyond them. Of course, we've got to pay attention to what the Clinical Laboratory Improvements Act rules are. The FDA, ASRM SART has guidelines that we follow, and of course, OSHA standards are always in play. But 40% of our standards actually go beyond what is written in stone so that we can better add to good patient care and obviously safety. And that safety is for both patients and for our employees. We need to keep current with the changes in laboratory medicine. If people had told me now, when I started that we would be doing some of the procedures we're doing now, I would have said, you're crazy. ART has come a really long way in the 30 years I've been involved. Technology has changed. The regulations, heavens knows that those have changed over time. We didn't even have FDA regulations when we first started. Those came into play in 2005. So what we want to do is take the best practices across all standards to try and create laboratory excellence. As I mentioned before, this is a reciprocal, peer-based inspection method. The laboratory-led inspection teams are laboratory professionals. So if you are an andrology laboratory only, you will be inspected by someone that has andrology as a specialty. If you are an embryology laboratory, your inspector will also have embryology experience and direction. They are going to look at all aspects of your lab. So if you have, as I've said, a chemistry section that you are doing in your ART section, we're going to have a checklist for the chemistry section as well. You can't do the continuing education to the same level that would replace what our real world experience can do. And we have fresh inspection times every cycle. So you're not going to have the same inspector each year, but rather you're going to see a number of different folks coming through every 2 years. And this really speaks to the opportunity to learn from the inspectors as well as the inspectors learning from you. I know every time I go out on an inspection, I bring back some pearl that I have not thought about before. And this is just a benefit of being an inspector, which you will be doing if you become a CAP lab. The lab team will be aligned with the lab test menu. The inspectors receive their training prior to doing your inspection, and we've got 2 different ways of accomplishing that. CAP has an extensive website with all sorts of helpful tools, and within that, they have online training for the inspectors. It takes about 2 hours to go through the modules, and then there are self-tests that you need to conduct. Every other year at ASRM, we actually have a live inspector training session, which goes for 1 entire day during the weekend prior to the actual meeting, during the post-grad courses. It's usually on Sunday, but we can't promise that. It's when we can get the room. And it's usually put on by about 4 of us that we can address embryology, andrology, chemistry, because that's a big one, and then cryopreservation, which is also an important topic. and it's become even more important in the last couple of years. So your inspection team is trained, and when they walk in the door, they are ready to get to work with you going through your laboratory. The custom checklist is specifically for your lab based on your testing menu. So when you are filling out your application, it's really important that you make sure that you include all aspects of your testing and include that on your application so that you get the appropriate checklist. We cannot inspect things that are not on your checklist, and we would have to come back and do that again. It makes it really nice because some labs only have 1 or 2 people. Other labs, I have heard, 15, 16 people, depending on the huge size of the laboratories. So your inspection team, we hope, will be unobtrusive and appropriate for the size of your laboratory and for the complexity of your checklists. Everything that we do is a continuous quality cycle. It begins one day with your first inspection and continues on for a year when you have a self-preparation cycle. You are looking at your own lab, looking to see what areas need to be improved, give yourself citations, and then at the 2-year mark, we come back and do it all again live with the inspection team. So from application to completion, the CAP is going to give you experts available to help you with what you need to do to have the best lab possible. We have an online training course, as I mentioned, getting ready for your first inspection. And I think it's a very useful tool for those of you that have not undergone an inspection prior. There's an inspection preparation worksheet, the checklist that gives you the most common deficiencies that we see when we go out on inspection teams. You get your customized checklist, and then you can also access the webinars that drill down on some of the important parts of compliance. For example, we've got specific webinars and podcasts dealing with doing your compliance test, your compliance for your staff, for quality management areas. When you are ready to get inspected, you're going to get an onboarding call from the CAP to make sure that you have everything in place for that inspection to occur. So they're going to be there from the first day that you submit your application to when you get ready to actually have your inspection scheduled. We look at the overall best lab practices. It's going to be different for every laboratory and how these practices are accomplished. We as CAP inspectors are not going in to tell you what you have to do. We are not going to tell you what temperature you must keep your incubators at. We are not going to tell you what media you should use. What we are looking to see is that you have established a plan for a very quality management of your laboratory. We want to know that the laboratory director is involved in every piece of this. Whether the director is a PhD or an ELD or an MD, the laboratory director must be involved throughout the entire process of directing the lab and laboratory inspection. We want to see that all of your staff are well trained and that their competency for their training is assessed according to the 6 standards that are required. And we've got tools to help you do that. We want to make sure that the policies that you have written in place are clear and that the procedures are able to be understood well by all of your staff. So again, we don't tell you what to do, but we want to make sure that you have decided what needs to be done to run your lab efficiently and in quality management. And we want to know that you have done all those things that you've planned for. The director assessment checklist looks at the amount of laboratory director involvement, and it's very important. We want to see what activities have been delegated to others within your laboratory. There are some procedures that are not delegable, and so we want to make sure that the laboratory director has kept touch of those. We want to look to see what kind of on-site visits or laboratory meetings, especially if you've got an off-site director situation. Most important, and to me, I think one of the most important things is the safety of the staff, the environment, and the patients. Making sure that everybody is working in a safe environment and that your patients are safe also. In my perspective, our patients are the ones in the dishes, and we must make sure that they are well cared for. We want to check to see that the director has an updated quality management plan, that it's being evaluated, and that it's being used for further improvement. We want to see that staffing levels are appropriate. Proficiency testing is done, it's done correctly, or if not done correctly, that the director has spoken with the staff that have had issues to bring them up to competency in that area of testing. Performing the self-inspection is a director assignment that has to be done every other year, not in sync with the live inspection. We want to see that the director has excellent communication with the staff, not an occasional email, but do they really check in with the laboratory to see what's going on? Do you have methods verification and validation for your equipment and procedures? Have the policies and procedures been reviewed annually? Have the laboratory staff had an opportunity to review the procedures, and have any questions or concerns been answered about those? The lab director is a really busy person and needs to be involved in order to run a good laboratory. This is one of the questions from that lab director section of the checklist. Does the laboratory director ensure an effective quality management for the laboratory? This is a question that unfortunately we see cited very often because the laboratory director does not have sufficient documentation to show us that they've got their thumb on the system. So this is a question that when you are getting ready for your inspection, take to heart, take a good look at it, and make sure that you can document. We've got 12 elements within what we consider a quality management plan. One is the leadership in the organization. Who does the director report to? How does he function with the organization? And how does the organization respond to what the director asks for? And I'm not just saying, do they buy you the latest and greatest piece of equipment? But if you have a staffing issue, does the organization respond to at least evaluate? There's got to be a give and take. Customer focus is job one, as was said by, I believe, 4 years ago. It is for us too. We have to take care of our patients, we have to take care of our embryos, and we have to make sure that we always keep our eyes on that prize of best quality embryo culture, best quality testing, error-free testing. We want to make sure that personnel are appropriate for the job, that they meet the criteria, that they have the appropriate degrees and training, and continuing education for that matter. The equipment we look at under the quality management plan, is it current? Is it safe? Is it maintained appropriately? Do you have a supply inventory system for your laboratory so that you don't run short of media or that you don't run out of dishes? Or in our case right now, masks are in short supply. Do you have a system to make sure those things don't happen? If you have an information system, do you have all the information about that system so that if it goes down, you know what to do, that you have a backup system? Do you know that it is a secure system as far as HIPAA? Do you have methods for error detection and management of those errors in your testing laboratories? Have you performed your self and on-site assessments? The proficiency testing is done at least twice a year, in some cases 3 times a year, for example, if you're running beta HCGs. Are they done correctly, and has the laboratory director signed off on it? Have you established your benchmarks for your quality assurance monitors? And again, environment and safety. You want to ensure patients and staff are safe. You want to make sure all areas of the laboratory are covered, from the front office to the laboratory to any areas where the patients may be. And you want to identify any safety risks or hazards. Is there a cord out of place? Are your hallways cluttered? These are things that are looked at as we do the inspection. One of the big areas that we've looked at in the last couple of years is liquid nitrogen and liquid nitrogen storage of embryos and gametes. We've had a couple of issues that have been publicized nationally and we have beefed up the checklists to make sure that we've got everybody doing their utmost to keep people not only safe, but their embryos and gametes safe also. In the general checklist, we're looking at all areas where nitrogen is used to make sure that there are oxygen sensors with a low oxygen alarm where there's an asphyxiation risk. You may have heard that one of the employees in Zytex died, unfortunately, when going into a room that had liquid nitrogen that had off-gassed into that room. We also have to be extremely careful that we've got ways to make sure that the embryos or gametes that we have in storage are able to be found and that they are appropriate for the person they say they are. We're looking for specimen labeling and tracking. We're looking that you have a method to determine that if we have a specimen that seems to go missing, that you can find it again by doing your planned search for that specimen. We want to make sure that any cryopreserved specimen is easily able to be found and that records are available for every specimen that is stored in the cryobank. The other checklists that you may see are endocrinology, laboratories that are performing their own PGTA. Hematology tests are sometimes performed in our art labs. And for those laboratories, it's a little bit more difficult because those of us that were raised in animal physiology laboratories didn't have to deal with validation and verification of testing. So CAP has a number of ways to help you identify what you need to do to be compliant, how to appropriately perform that validation or verification, how to determine the AMR verification, and your quality control requirements for those unique tests. So they've got your back. I think, Jean, do you want to address this at all?
Sure. Thanks, Dr. Benke. Having inspected at many reproductive laboratories with your seasoned embryologists, I can tell you that most areas cited are not in the embryology or the reproductive laboratory section. They're in the laboratory general or all common areas. We commonly see deficiencies cited in reproductive laboratories related to quality management indicators or benchmarks, competency assessments, including all of the required elements, proficiency testing failure investigations with corrective actions, monthly document review like QC and maintenance logs and temperature monitoring during days when the clinic or laboratory may be closed. We have resources available to help our accredited laboratories with all of these issues. So there's no question that achieving and maintaining laboratory accreditation is vital to providing high quality patient care. The question then becomes, do we want the opportunity for our laboratories to be the best, to drive for continuous quality improvement to help ensure the best possible patient care? With the rate of change in laboratory medicine today, can we really afford not to? We have reviewed just a small sampling of our checklist requirements, as well as the benefits of the CAP accreditation program. If you have questions at any time, we have resources available at cap.org, as well as free Focus on Compliance webinars. In fact, there's a webinar specifically focused on laboratory director involvement next week on July 15th. You can register for that through the CAP website. You can also call or email any additional questions to the contact information listed above. Thank you for your interest in laboratory accreditation and the College of American Pathologists.
Good afternoon. I'm Vicki Livingston, Laboratory Surveyor for the Joint Commission. I want to thank you for the invitation and the opportunity to present to you today. I am a full-time surveyor with the Joint Commission, but in the absence of surveys at this time, I volunteered to be your speaker today. I want to share with you some of the unique features the Joint Commission has to offer to their accredited organizations. So here is let's start with the vision and mission of the Joint Commission. So the vision, all people always experience the safest, highest quality, best value healthcare across all settings. And our mission, to continuously improve healthcare for the public in collaboration with other stakeholders by evaluating healthcare organizations and inspiring them to excel in providing safe and effective care of the highest quality and value. Here are some updates to our survey and review process in light of COVID-19. And I do want to take this opportunity on behalf of Dr. Chasen at the Joint Commission. We want to thank all of you who are providing care during this pandemic. We understand people still want to have babies, and others still want to preserve their eggs or sperm so they can start their cancer treatment. These things simply can't wait, and your sacrifice and dedication has not gone unrecognized. We have put in place some physical distancing requirements when we come out to survey. And yes, we have started surveying again. We did stop in probably middle of March, and all surveyors were kept very busy with various projects and team activities. But the Joint Commission has worked out a way to look at every zip code throughout the United States and determine if it's safe enough to send a surveyor in to do a survey. So when we do come out now, we have some physical distancing requirements. We are limiting large in-person sessions, and we encourage some virtual options. In fact, Joint Commission has now started doing virtual surveys. It really started here in Florida where I live for some nursing homes that had applied for their initial surveys and just had not had their in-person survey before the lockdowns were enabled. So Joint Commission offered some virtual surveys. They were so successful. They have now expanded that to all of our programs, all the types of accreditation programs that we offer, including laboratory. So CMS gave us the approval to start performing virtual. There are some additional requirements that, and don't think that there's never an on-site visit. When the pandemic is over and it's declared safe, there will be an on-site visit. But there are certain things that we can do virtually. Even today, this meeting that we're having, some unique opportunities. And then we do have some survey and review process modifications in place just to protect the staff and the surveyors. But bottom line, we want to know we are here to support you. By the way, we do have a number of best practices for COVID on our website. So if you haven't taken a look at that, please, that's updated almost daily. So I invite you to go to our website and take a look. Let's talk about the survey process objectives. They are to validate your compliance with our standards, to provide a meaningful assessment of risk, both known and unknown, to inspire and encourage improvement through engagement and dialogue with your staff, physicians, and leaders, and to assist you in your journey toward becoming a highly reliable organization that provides consistently safe, high-quality care to every patient, every time. The Joint Commission is very outcomes-driven rather than process-driven. And it's my understanding that SART is also outcomes-driven. I believe you have elected to submit data that needs to be reported to CDC through your own organization, SART, at additional expense. I believe you can report to CDC directly for free, but you have taken it upon yourselves to report through your own organization. And in addition, you are also collecting other data that you do voluntarily. And as a result, you have achieved a much higher success rate over the years. So congratulations. The Joint Commission is committed to assisting organizations on their journey to zero harm. I know that when a member of my family needs health care, I do not want anything to happen to them. So zero harm has certainly become a driving entity for us. Zero harm in laboratories. The Joint Commission Enterprise envisions a future of zero harm and is committed to helping make it a reality in laboratories. Wouldn't that be wonderful? We have some suggestions to achieve zero harm in laboratories. So here are some tactics that your laboratory can implement. Improve internal self-audits, evaluation, and follow-up for complaints and accidents. Create an environment in which employees are comfortable reporting all safety infractions. Monitor improvement initiatives and review processes throughout the organization to identify high-risk procedures. Evaluate processes for addressing near misses, and ensure everyone is focused on patient safety. This is where the leadership of the laboratory is so vital to put into place those processes that are known to contribute to zero harm, such as a just culture. We've all heard about the large number of deaths each year in healthcare organizations and other various mistakes. Unfortunately, IVF laboratories have not escaped mention in the press. I believe there's been couples with the wrong child, so patient identification mistakes. Now with these new assays that we can all buy and have our DNA tested, maybe in the future we're going to find out that some other mistakes have been made. But we want to help you prevent that, so the goal is zero harm. We do have a number of helpful resources. The Joint Commission Extranet and the TJC website contain multiple resources for additional information. We have accreditation and certification data updates. We have heads-up reports. We have links to targeted solution tools. That's what TST is. We have perspectives that we publish monthly. We have prevention portals. We have R3 reports, and we have Sentinel event alerts. These are all accessible to you on our website. I believe we have a slide here showing you highlighted for an accreditation data update and how to access it. So I wanted to mention SAFER. This is one of the things that Joint Commission instituted several years ago to help organizations identify risks. So the survey analysis for evaluating risk, or SAFER as we call it, is an approach for identifying and communicating risk levels associated with standards noncompliance cited during surveys. The information related to risk provided by the SAFER matrix helps organizations prioritize and focus corrective actions. Surveyors use the SAFER matrix to organize and prioritize content for review at daily briefings. And the survey report will contain the SAFER matrix. Here's an example of our SAFER matrix. I like that it's in color. You'll see the y-axis is the likelihood to harm patient, staff, or visitor. And as the surveyor places the finding on the SAFER matrix, they decide if this likelihood to cause harm is low, moderate, or high. And they also look at the scope, which is the x-axis. Is it limited? Is it a pattern? Or is it widespread? At the exit, you will see this as part of the survey report. One of our hospital surveyors was asked to describe this, and I kind of like his explanation. You desire to keep the findings from your survey down in the yellow mustard, low and limited. Sometimes they might get up into what we call the Gould's mustard. And worse yet, if there's more likelihood to harm, you might end up in the ketchup level, which is the high level. But God forbid you don't want to end up in the barbecue sauce, which is the immediate threat to health and safety. This is potentially where something could be scored, like the lack of the oxygen monitoring with the liquid nitrogen. Surveyors pledge to be transparent, collaborative, and educational with sharing leading practices and resources. Our surveyors are highly trained, experienced laboratorians. Myself, I am full-time and perform approximately 60 surveys a year. This gives us a vast amount of knowledge that we can share. Initially, all surveyors go through extensive training, face-to-face, didactic training, and online training. Before surveying independently, a new surveyor completes at least 6 surveys with a preceptor. Annually, we are required to complete online training, and we attend training with subject matter experts at least annually. Surveyor evaluation. The Joint Commission welcomes your feedback on the performance of surveyors and will ask you to complete an evaluation following the survey. They only take a few minutes to complete, and you will get a link to complete this evaluation when your survey report is posted to the extranet site. These evaluations are designed to keep our surveyors performing at the top of their game. So the surveyor continually receives feedback on their performance. Survey preparation. The organization fills out an application which is reviewed with an account representative. These account reps are highly trained and become your contact person whenever questions arise. They are extremely knowledgeable. They give you a list of documents to have ready for the survey day, and they give you a tentative agenda, which is reviewed and discussed with the organization. On the day of survey, the notification of the survey appears on the organization's secure website at approximately 7:30 in the morning. Along with the notification, there is an agenda posted. IVF labs get advance notifications so that the survey should not interfere with patient care, and so all appropriate staff can be present, meaning the laboratory director, the embryologist, etc. The agenda itself includes an opening conference, regulatory review. During that regulatory review, CLIA certificates would be reviewed, and we do ask our organizations to fill out a CMS 209 form, where you list the qualified laboratory director and the technical supervisors for each CLIA specialty. That form is reviewed in person the day of the survey. Then we do proficiency testing review for the CLIA analytes and embryo development and quality. We review safety, including high reliability, fire, infection control, emergency preparedness, and performance improvement. The emergency preparedness is particularly appropriate for your IVF labs. I know we've all heard stories of Katrina and how those embryos were rescued out of New Orleans. We've had now pandemics, and also along with your emergency preparedness, the role of the embryologist is so vital that you have to have a plan to cover any unanticipated absences. We do a laboratory tour. The surveyor reviews the environment of care during that tour. And then we do tracer selection, which is again very unique to the Joint Commission. Our survey activity is actually driven by the tracers. So if it's an initial survey, the tracer selection is limited to the previous 4 months. If it's a regular full survey, tracers are selected from 12 to 24 months, 6 to 12 months ago, and within the past 6 months. So in other words, we would select tracers who have had testing and embryology done within the previous 2-year time frame. When we look at tracers, we review the medical record to see the report that has been placed in the record and along with any other documentation. From the dates of testing, that's how the surveyor gets to review the affiliated quality control, including any method validations, policies and procedures, calibration verifications, etc. The laboratory also identifies who did the testing so that later the HR and competency can be reviewed for those specifically identified individuals. Continuation of the agenda, we do that competency and HR review. And I just have to mention, last October, I did have the opportunity to present the Joint Commission's top 10 findings from laboratory surveys at the Quality Confab in Atlanta. CAP was there along with COLA. So all 3 accrediting organizations shared their top 10. And guess what made #1 for all 3? Competency. So I can't impress upon all of you enough. There are the 6 methods that we're all familiar with, and the surveyors are looking. The preliminary report with the SAFER matrix is posted to your secure website. And this is discussed with you at the exit conference. This is a preliminary report, but it typically becomes the final report when the surveyor submits the findings to our central office. The Joint Commission standards, these are developed in conjunction with the subject matter experts. And I know we do have representatives from SART that serve as our subject matter experts. They are reviewed 2 times annually. They are revised whenever regulation or standards of practice are changed or revised. And we just published the perspectives for July 2020. The embryology standards have been updated and will be implemented effective January 2021. Here's some contact information for you, but I can't end without saying in the years that I have surveyed with Joint Commission, and I'm now in my 17th year, I have met so many dedicated embryologists who seem to work 7 days a week. They come in extremely early in the morning to accommodate patients who must be evaluated prior to their own work day. I just applaud all of your efforts, especially at this time of COVID, and wish you continued success. You've made so many improvements in the 20 years, and I'm excited to see what you do in the future. Thank you so much for this opportunity to present.
Well, thank you so much, Vicki and Eric. I really appreciate both of you taking the time to share give us more insight about CAP and Joint Commission's approach to laboratory accreditation. It's quite clear that you're looking for the best interest of the patient, as well as assuring that the laboratories are performing at the level of expectation, but exceeding those expectations that are set forth by the federal law, CLIA. We do have a few questions that we'll start with. I'd like to just start off with a confirmation that many I think subscribers to this webinar are familiar with CAP, and we know that CAP covers both embryology and andrology as well as endocrinology. But just to clarify, that Joint Commission also will look at embryology, andrology, endocrinology, and other functions, correct?
Correct.
So both accrediting agencies will inspect labs for all of those services, as well as others if you happen to offer those services. So looking at the inspection process. So what if I am cited for a deficiency that I would like to challenge during the inspection process or afterwards? Maybe each of you could address how it's handled with your organization. Vicki will give you a little bit of a breather. Erica, if you could start with how CAP would handle it.
Sure. When we do our summary conference at the end of the inspection and go over the various deficiencies that may have been cited, we encourage the laboratory director to challenge anything that they feel was cited in error. Many times, piece of documentation during the time of the inspection, they know where it is, they just can't find it. And a helpful hint to people getting ready for inspections is take your checklist and write down where your documentation is found ahead of the inspection. Immediately go to it. But let's say that they've got something they felt really wasn't cited correctly. The form that they will fill out that just says that I would like to challenge this item, that it goes back to the reviewing commissioner. We have 3 reviewing commissioners. There's East Coast, Midwest, and mine. And then we evaluate based on the documentation that is sent to explain why they feel it was an error and what the real situation is. If there is enough substantiation, if that document was found and it was clearly written before the time of the inspection, then we will expunge that deficiency. It's as if it never happened. If, however, the documentation does not support the expungement, then it will stand as a cited deficiency and the laboratory will have to respond to it as a deficiency.
Okay, thank you. How would this be handled with the Joint Commission inspection?
Okay. During the survey, if any questions come up regarding, well, I don't think that's really a finding, we have the opportunity with our tablet to ask our standards interpretation group. We can either reach them by phone or actually put the question into our tablet and get an answer in real time. So that's typically very, very helpful. We have a process that we call clarification, but we no longer accept documents after the survey. You either have to have the document during the survey or it counts as a finding in the report. Now, other things, if there's different viewpoints about whether this is actual a finding or a misinterpretation of a standard, that can still go in for clarification. But remember, we're trained surveyors. We're doing, like myself, 60 surveys a year. The rate of those is very minimal.
And just as a follow-up, Dr. Benke, with CAP, are the inspectors, so let's say a deficiency's been challenged and it's been successfully challenged. Is the inspector made aware of that? Because I think with Joint Commission, the inspector, that's their job. They're aware that maybe that was eliminated, but would the volunteer inspector be informed of that change?
It kind of depends on the situation. If it's something as simple as having a document submitted after the fact, no, we wouldn't. But if we're seeing the inspectors doing citations that really are not appropriate, we call them inspector errors, then we frequently will go back and work with that inspector to give them feedback. All of our inspectors receive feedback at some point after their inspection. Usually it's positive feedback, but every once in a blue moon, we have to have a little chat, and sure. It's all an improvement.
Let's lighten the mood a little bit with maybe a slightly easier question. There's been some debate about the oxygen sensor. I mean, that has become a real focus since the lithium disasters. Is there a specific height where the oxygen sensor should be installed, lower or shoulder height of the shortest person in your lab, or is there some reference point? I thought that was a good question. Does either agency have a standard for that?
We don't have a standard for it, but other than you have to have one, we would suggest probably around the 4 to 5 foot mark. Again, you want to make sure that you don't have your shortest person being excluded by the height. You know, if the person that installs it says it's at my breathing level and he's 6'2", that's not going to help your 5'2" embryologist. So yeah, I think 4 to 5 feet is probably appropriate for that.
Vicki, does Joint Commission have a very specific height?
No, we don't.
Okay.
But if that subject came up during a survey, we do have subject matter experts that we could refer to. We do have our standards interpretation group. And then we also have some engineers that might be of assistance to us.
This is a nice broad question. So how do your agencies do a quality control or quality assessment of the inspection process? Maybe you could address it first for Joint Commission.
Well, if it's a CLIA laboratory, we do have validation. CMS comes in and does validation surveys, and that's publicly reported how we agreed, or the disparity between the CMS report and the Joint Commission report. So there's one piece of it right there. We also have our field director, who is our boss, come out usually every other year and follows the surveyor to make sure that they're doing what they need to do. And then remember, we have those surveyor evaluations that each organization fills out. And trust me, if there is anything that needs to be addressed, the field director gives you a call.
Okay. Erica, how does CAP handle it?
It's very similar. Again, we have the CMS, follow-up inspections. And those are usually when I get the irritated note. They had an inspection and a week later CMS came behind them. Occasionally it will be done simultaneously. I was accompanied by a CMS inspector on at least 2 of the inspections I've done. We also have the post-inspection survey that everyone gets to fill out and gets to blow up my inbox. And fortunately, the majority of them are pretty good, but occasionally it will help to identify not a bad apple, but somebody that might need a little additional coaching in their method of performing that inspection. And then the CAP also will send out somebody to go on an inspection visit. I'm always happy when it's Jean Ball, but they will send a state inspector or someone else along that is grading the inspector. I can tell you that I had an inspection of my rather lab, and I had 4 inspectors there, 1 from each agency. So it's just how the dice roll sometimes. But it is important that we keep tabs on how well we're doing. I can also tell you that I enjoy lurking on Mavericks, but most of my feedback.
Yeah, fair enough. So in that line, CAP had added a second general inspector to accompany.
Yes.
We'd have just 1 inspector. Will they continue to have that second inspector, or is there a plan for change?
We are probably going to have more second inspectors, frankly, because the laboratories are getting larger. We're seeing a lot of labs merging, and the complexity of the laboratories and the complexity of the checklists. You know, when we first started out and we had 1 inspector, we didn't have biopsies, we didn't have ICSIs, we didn't have extended culture. Quite honestly, it's become complex enough that I think the 2 inspector format is a good one. What we're seeing, though, is that the second inspector come from the reproductive lab rather than necessarily being a lab general. There was some concern that some of our inspectors were not looking at some of the lab general things as tightly as we needed to. So CAP did a 2 years trial, sending out each lab general inspector along with reproductive. And I'm very pleased to say that we did well. And they've agreed that we are actually competent to mind our own shops, so to speak. On some of the labs, I'm still going to ask for a lab general person, particularly a lab that has a lot of ancillary checklists, chemistry checklists, heme checklists, because those folks are really good at it. And that way I have more time to look at embryology and andrology.
Fair enough. And Vicki, if we're undergoing an inspection with the Joint Commission, how many people can we anticipate visiting our lab?
Oh, okay, well, that really depends on that application that you fill out, the number of CLIA specialties that you indicate, whether you're doing the embryology and the andrology. It's like Kentucky Fried Chicken's secret recipe, but there is a formula that Joint Commission uses, and when we go into some of the larger IVF centers, we do come in with more than one surveyor.
Yeah. Are you typically able to get the inspection done in a single day?
Most of the time. At the smaller ones, yes. At the freestanding smaller IVF clinics, yes. But it's a busy day.
Yeah, for sure. So for both of you, again, if you have a program that has a high number of deficiencies or a single catastrophic event, maybe they were in the barbecue range, the safety matrix, what is the process for accreditation, revocation, and then reinstatement? Vicki, if you don't mind starting.
Well, if you make it into the barbecue sauce, now that's a very serious immediate threat to life. The Joint Commission has an entire process for that. That determination is not made by the surveyor, by the way. So if a surveyor thinks this may be immediate threat to life, we have a process to follow. And Dr. Chasen has kept that process under very tight control. He and one other physician at Joint Commission are the only ones who can declare an immediate threat to life. Okay. Now, as far as the reinstatement, that gets too complex. It really depends on the type of finding that was identified.
Okay, thank you. Erica, how would CAP handle a similar situation?
First, let me make it clear, when your inspection is completed, the inspector sends all of the materials to the CAP office where it's reviewed by a technical specialist. And at that time, then they send it out to the reviewing commissioner. So the inspector does not have the ability to say, you're good to go, because we get to rubber stamp that. If we have a laboratory that's got some significant issues, and we've got some checklist items that are targeted, that if those are cited, it triggers the review process. It's called a focus factor, and once you exceed a certain level, then it has to go to the accreditation committee. The reviewing commissioner will be involved with the accreditation committee, which is a large group made up of a number of pathologists and others that are on that board. We tell them what the situation is, what has been cited, and the reviewing commissioner will make a recommendation. Most often, we can do an accreditation with requirements. We can ask for additional documentation throughout the year. If somebody's got a problem with their quality indicators, we may ask to see 4 quarters of their program review. But if it gets to an egregious level, then we will ask for a non-routine reinspection, so that we send another team out to, after the group has been told what their problems are, we send another group out within 6 months to evaluate what the laboratory's function quality is at that point. And then it goes back to the accreditation committee, and they can choose to revoke their accreditation or put them on a probationary status, and they cannot reapply until they have a certain amount of time passes and that they've resubmitted their data. So again, it's a lengthy, not to be taken lightly process, but it's an ongoing thing. I use accreditation with requirements. Maybe 20% of the laboratories will have to fall under that category, because there's just something that I want to make sure we looked at it. It had some issues. They say they fixed it. I want proof that they fixed it and that they keep it current. And then the ones that have to have re-inspections, not very often and very painful.
Well, thank you. That helps understand that process. I have a final question that was submitted before the webinar, and I think it recognizes how these inspections and your inspector can actually serve as an advocate for the laboratory director. The question is, if a laboratory does air quality testing and fails, is there an entity that cares about that? And I think the concern is that it may be part of the quality management program of the laboratory. And if they have a failure, the air quality isn't very good, they would like to make sure that their clinic is aware of this and supporting them in correcting that problem, and perhaps they aren't getting that support. So I'm just kind of curious how each agency would help advocate or defend the laboratory director in trying to get them the good air quality that they are desiring for their embryo lab. Vicki, do you?
Yeah, I did have a chance to see that question before we started today. And, you know, that takes me back to the high reliability that I spoke about earlier, and the responsibility of the laboratory director to establish that just culture and make the staff feel comfortable that if they see something unsafe, and apparently this person's very dissatisfied with the air quality, that's okay. They need to speak up. And there needs to be a process that allows the employee to do that. But if that fails, all Joint Commission accredited laboratories are supposed to educate their staff that we have an 800 number that they can call anonymously and report an instance that they feel needs further investigation. And that goes to the Office of Quality and Patient Safety that we have. That's a very good resource. They're very skilled at helping the organization get to the bottom of it, and it actually goes through a very extensive review process at Joint Commission, where it may be determined that they need to send a surveyor out to specifically review the complaint.
Okay, thank you.
Good question.
Yeah, it is. Erica, how would you
I'm still here.
Yeah, I know you're still here. We'll give it a minute.
You know, we don't have a specific, there we go. We don't really have specific requirements for air quality or testing. If it's part of their QM program, of course, then it does need to be addressed. In any case, what I would want to see is that the director acknowledges that the problem has been identified and that they develop some sort of an action plan. If that is to say, we have a problem, we cannot move our facility, but perhaps we will try inline filters or code a tower or some other type of mitigation, or that they're going to bring in the company that did the air testing. We've got specialists in our field that do that, and look at what their recommendations are for mitigating the problem. We also have the anonymous program that if you've got an issue, you can write into or call CAP and tell them that you have a concern.
Yeah.
You know, we've got a situation that a number of the laboratories are either hospital owned or they're privately owned by physicians. And as much as I'd like to say, if we identified an air quality concern, I want to move, it's not going to happen. So what the best that we can do is to make sure that the director has a good communication with the organization, if it's a hospital organization or if it's their physicians, let them know what the problems are, let them know what the ramifications are, and then on the inspection, perhaps the inspector can cite something under the safety area. They're only phase ones. They're only informational. We can't require them to move, but we can certainly make it known to whoever this report is going to be seen by that there is a significant issue that the director in good conscience would like to see addressed, and we would support that. I'm very happy to give space citations when people say we don't have enough room. Sometimes if we can say, yeah, we really don't have enough room, that shakes.
Yeah, it only took me 27 years, but I finally got the nice lab I wanted. So thank you, Cap, for continuing to support me, saying these facilities are inadequate. No, I do think that both inspection processes do help advocate for the laboratory within the larger center. Well, with that, thank you so much to both of you for sharing your insights and for all of your work that you do with both agencies. I'll turn this back over to Jessica.
Thank you to our panelists and attendees. You will receive a survey by email after the session. Your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. For further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.